Good afternoon, and thank you for the opportunity to present our project. Today, we'll walk you through our analysis of emergency department wait times and share a set of actionable recommendations focused on organizational redesign and targeted AI integration. We approach this work as consultants would for a health system client by examining the ED end-to-end, identifying root causes, proposing solutions that are realistic, scalable, and aligned with frontline workflows.
Emergency departments are a cornerstone of the U.S. healthcare system, serving as the primary access point for urgent and life-saving care for millions of patients each year, including many who lack consistent access to primary care or health insurance. In 2022 alone, U.S. emergency departments recorded approximately 155 million visits, underscoring the immense demand placed on the sector. Despite this volume, only about 40% of patients are seen within the first 15 minutes, highlighting persistent access and throughput challenges. While emergency department crowding has existed for decades, the severity of delays has escalated dramatically in the recent years. Nationally, average ED wait time have increased to nearly 2 hours and 42 minutes per visit as of 2024, compared to just 24 minutes in 2014. Healthcare professionals increasingly recognize that these prolonged wait times reflect system-wide failures, not just inefficiencies within the emergency department itself. These delays have serious consequences for patient outcomes. Research shows that ED crowding and extended length of stay are directly associated with increased mortality, particularly for patients with time-sensitive conditions. Long wait times also erode patient satisfaction and trust, contributing to high rates of patients leaving without being seen. The problem is widespread. Over 90% of emergency departments report crowding. A major contributor to this crisis is patient boarding, where admitted patients remain in the emergency department due to a lack of inpatient bed availability. Currently, 1 in 6 admitted ED patients boards for 4 hours or more, further straining staff and resources. Community hospitals are especially affected as they often operate with fewer beds, limited staffing, and less operational flexibility than large academic centers, making them particularly vulnerable to worsening wait times and operational stress.
To start with the high-level summary, emergency department crowding has intensified into a nationwide patient safety issue. More than 90% of EDs report routine overcrowding driven by rising patient acuity, staffing shortages, and extended inpatient boarding. These delays are associated with higher mortality, lower patient satisfaction, and increased rates of patients leaving before being seen. Community hospitals face even stronger constraints due to limited beds and fewer clinical resources, which disproportionately impacts vulnerable patients such as older adults and individuals with dementia. Our proposed solution focuses on redesigning the organizational foundation of ED operations, strengthening communication norms, clarifying workflows, building psychological safety, and then layering in AI tools that support triage accuracy, predictive staffing, and real-time bed management. This combination allows hospitals to reduce avoidable input, improve throughput, and accelerate safe patient placement.
Our background analysis showed that ED wait time reflects more than staffing or space limitation. They are the downstream results of multiple forces: limited access to primary care, rising chronic disease burden, demographic changes, and policy pressures. These all push more patients toward the ED. Using the input, throughput, output model, we found 3 sets of barriers. Input, which include limited primary care access, lack of insurance, and rising chronic diseases. Throughput, which include diagnostic delay, staffing shortages, and inconsistent triage workflow. And finally, output, boarding due to limited inpatient capacity. Community hospitals feel these pressures more intensely because they operate with fewer resources and less operational flexibility. As a result, small inefficiencies quickly become significant delays.
For our analysis, we found that ED delays actually stem from organizational barriers, all of which reflect deeper issues in team structure and culture as opposed to simple capacity problems. First, there's structural fragmentation, in which teams and departments operate in silos with unclear coordination mechanisms. Without shared goals or aligned workflows, even simple tasks can slow down, and improvements such as adding staff doesn't actually translate into better flow. Second, there's miscommunication. As explained in the course concepts, teams with different communication norms struggle when expectations aren't explicit. In the ED, unclear escalation pathways and inconsistent documentation make handoffs inefficient and create preventable delays. Third, there's low psychological safety. When staff doesn't actually feel comfortable raising concerns or challenging processes, the issues remain unaddressed. The class concept discusses the last 8%, which highlights how teams avoid difficult conversations and lead to workarounds instead of actual, real, substantive change. And finally, team-based diversity misalignment. Drawing from the class concepts, when teams lack diversity-sensitive orientation, meaning they don't actually fully leverage different backgrounds, perspectives, or communication styles, collaboration then suffers. In the ED, this can look like breakdowns in teamwork, misunderstandings across roles, and missed opportunities for problem solving. Altogether, these barriers show that ED wait times are not just an operational issue, but a reflection of structural and cultural limits within the organization. Addressing fragmentation, communication norms, inclusion, and psychological safety is essential before introducing a solution to triage any system-wide change.
Our recommendations are intentionally sequenced because the ED environment is complex and interdependent. First, strengthen the organizational foundation. Clarify communication pathways, standardize workflows, build psychological safety, and establish a dedicated ED flow steering committee to monitor KPIs. These steps ensure the environment is ready for more advanced tools. Second, introduce AI solutions that enhance, not replace, clinical judgment. AI-supported rapid triage to improve accuracy and reduce variability. Predictive staffing models to anticipate volume surges. AI-driven bed forecasting to reduce boarding and speed inpatient placement. Third, use a phased rollout. Start with a pilot group of early adopters to identify workflow issues, refine training, and model best practices before scaling department-wide. This approach reduces implementation risk and increases staff trust and adoption.
Stepping back, our project reinforced that ED crowding is not a single department issue, it is a system issue. The most effective path forward follows a clear sequence. 1. Strengthen culture and communication. 2. Redesign workflows and eliminate fragmentation. And 3. Introduce targeted AI tools to accelerate throughput. For health system leaders, the next steps include monitoring triage consistency, equity, and psychological safety, piloting AI tools before scaling them, building partnerships with community organizations to reduce avoidable ED visits. When executed in the right order, these actions help create a more resilient, equitable, and high-performing emergency care system. In closing our project work, we applied double loop learning, meaning we not only gathered data, but we also challenged our own assumptions. We began by viewing ED crowding as primarily a capacity problem, but through the literature and important healthcare organization and management concepts, we learned that organizational design, communication norms, and frontline culture are the real drivers. We also reframed our understanding of technology. Rather than approaching AI as a standalone solution, we recognized it must be embedded into a stable organizational foundation to produce meaningful results. Overall, this project broadened our lens for understanding healthcare operations and reinforced the importance of aligning culture, structure, and technology. Thank you so much for your attention and your time. We appreciate the opportunity to walk you through our analyses and recommendations. We'd be happy to answer any questions or delve into the specifics of our recommendations.